Hello all, welcome to our channel Polyhipster. In this lecture, we will be discussing about diabetes mellitus in brief. We will be talking about various categories, how to approach a case of diabetes, how to distinguish them between different types, and what are the different treatment options available. So let's begin. To begin with, what is hyperglycemia? It is the increased level of blood glucose in our body. So diabetes mellitus is mostly concerned with hyperglycemia. So if a person has that condition, what are the symptoms that indicate the presence of hyperglycemia in our body? First is polyuria, that is excessive urination, polydipsia, excessive thirst, unexplained weight loss, visual blurring, genital thrush, lethargy, etc. These are the few common symptoms seen in a patient with hyperglycemia. Next step is to analyze various testing parameters, starting with blood glucose level in the fasting condition. If it is more than 7 millimole per liter or 126 mg per liter, or random blood glucose level without any pre-preparation of the patient, if it is more than 11.1 millimole per liter or 200 mg per deciliter. Oral glucose tolerance test of 2 hours if it is more than 200 mg per deciliter or 11.1 millimole per liter, and then HbA1c, which gives a long-term idea of a person's blood glucose level over 3 months. If it is more than 48 millimole per liter or 6.5 percentage, we could suspect presence of diabetes mellitus in that patient. If we categorize different types of diabetes mellitus, mainly includes type 1 and type 2 diabetes mellitus. Other types include impaired glucose tolerance, impaired fasting glucose, etc. Starting with type 1 diabetes mellitus, it can occur at any age, usually in adolescence. It is autoimmune in nature and are associated with other autoimmune diseases. These patients are more prone to ketoacidosis and weight loss. Four genes are associated with these conditions located in 6q chromosome, which determines islet sensitivity to damage, either from virus or cross-reactivity from cow's milk-induced antibodies. Latent autoimmune diabetes in adults is also included in type 1, where there is slower progression to insulin dependence in later life. Type 2 diabetes mellitus, we can see impaired fasting glucose or MODY, which is maturity onset of diabetes in young, which is a rare autosomal dominant form of type 2 diabetes mellitus affecting young with a positive family history. Now, impaired glucose tolerance is a condition where fasting blood sugar is less than 7 millimole per liter and oral glucose tolerance test of 2 hours is more than 7.8 millimole per liter, but less than 11.1 millimole per liter. Whereas impaired fasting glucose, where fasting blood sugar is more than or equal to 6.1 millimole per liter, but less than 7. So in order to exclude diabetes mellitus, we have to do an OGTT. Now, what are the other causes of diabetes mellitus? First, it could be steroid induced or induced due to anti-HIV drugs, newer antipsychotics, or thiazides. So these are drug-induced diabetes mellitus. Next is due to pancreatic causes, such as in pancreatitis or pancreatic surgery, any trauma or pancreatic destruction, example, hemochromatosis, cystic fibrosis, or in case of pancreatic cancer. Third condition would be in case of Cushing's disease, acromegaly, pheochromocytoma, hyperthyroidism, or pregnancy. That is hormone-induced diabetes mellitus. And other conditions such as congenital lipodystrophy, glycogen storage diseases, etc. Another important topic is diabetes and pregnancy, which can be explained in detail in a separate video. To understand in brief, around 4% of pregnancies are affected with diabetes mellitus. This gestational diabetes mellitus can be predisposed by various factors such as family history, PCOS, etc. So, in such patients, in order to prevent it as a precautionary method, they could start weight control, folic acid until 12 weeks before conception. They can be screened for gestational diabetes mellitus with OGTT at around 16 to 18 weeks of pregnancy. If the patient is already a diabetic, then they should stop all other oral hypoglycemics other than metformin and should do a fasting glucose 6 weeks later. Let's compare in short the difference between type 2 and type 1 diabetes. As far as epidemiology is concerned, type 1 starts before puberty in most of the cases, whereas type 2 is seen in older patients. Genetics of type 1 is HLA D3 and D4, whereas type 2 has no HLA association. Causative factors of type 1, it is mostly autoimmune in nature and is associated with beta cell destruction, whereas type 2 is seen where insulin resistance is present or beta cell dysfunction is seen. Presentation in case of type 1 diabetes, polydipsia, polyuria, weight loss, and ketosis is prominent, whereas in type 2 diabetes, it is mostly asymptomatic or it could be associated with complications such as myocardial infarction. What is metabolic syndrome? It is a group of conditions which is present together in a patient, which includes central obesity, 2 BP readings more than 130 by 85, increased triglycerides level, increased HDL level, and fasting blood glucose more than 5.6 millimoles per liter, or a diagnosed case of diabetes. What are the possible consequences of metabolic syndrome? It could cause vascular events, complications of diabetes mellitus, neurodegeneration, microalbuminuria, gallstones, cancer, and fertility problems. What is the treatment for metabolic syndrome? Mainly exercise and weight reduction, Mediterranean diet, antihypertensives, hypoglycemics such as metformin plus minus glitazones, statins. And it is also noticed that mental depression is directly associated with insulin resistance, which is a common psychiatric complication associated with this condition. Let's talk about the treatment for diabetes mellitus in short. As far as type 1 diabetes mellitus is concerned, insulin is the main treatment of choice, whereas in type 2 diabetes mellitus, metformin is the drug of choice, which is a biguanide in classification. It increases insulin sensitivity and helps in weight reduction. What are the side effects of metformin? It is mostly nausea, diarrhea, and abdominal pain, but not hypoglycemia, which we should remember. Hypoglycemia is not a side effect of metformin. When should it be avoided? It is contraindicated if eGFR of a person is less than 36 ml per minute. Therefore, it can cause lactic acidosis. And dose of metformin is 500 mg BD after food. In which condition should we consider stopping metformin? First is when the patient experiences any hypoxic condition such as myocardial infarction or sepsis. The morning before general anesthesia for any surgical procedure, metformin should be stopped. Also, if the patient is undergoing any investigative procedure which includes contrast medium like iodine, metformin should be stopped prior to that. Once you start with metformin, HbA1c level should be measured 16 weeks later. And if it is still more than 53 millimoles per liter, we should add on the next drug, which falls under sulfonylurea category. The main function of these drugs is to increase insulin secretion. Remember, metformin, it had increased insulin sensitivity in the receptor. Whereas now insulin secretion has been increased. Example of such a drug is glycoside, which is given 40 mg per day. Here, the side effect includes hypoglycemia. Therefore, glucose should be monitored closely, especially in the beginning, still till the body gets adjusted to it, and weight gain. So we should remember first we gave metformin, which causes weight loss, and now we are giving glycoside, which causes weight gain. So we are hoping it gets balanced here. Now, if BMI of a person is more than 35, then we give an alternative, which is gliptins. Or if the patient is experiencing extreme hypoglycemia because of sulfonylurea, in those cases also we give gliptins as an alternative. Now, once the second drug is added, next the patient's HbA1c should be measured at 6 months. And if it is still more than 57 millimole per liter, insulin should be added, mainly isofin insulin twice a day or a long-acting analog. Or we can add a glitazone, which will increase insulin sensitivity further. Glitazones have few side effects such as hypoglycemia, fractures, fluid retention, and varied liver function. Therefore, we should do a liver function test every 8 weeks for 1 year once this drug has been started, and the drug should be stopped if the ALT levels increase more than 3 folds. What are the contraindications for glitazones? It includes the patient has or had congestive cardiac failure episode or osteoporosis or excessive weight gain or edema. Example of such a drug is pioglitazone, given 15 to 45 mg in every 24 hours. Next category of hypoglycemic drugs include glucagon-like peptides or GLP analogs. Their main action is by increasing the activity or effect of incretins. Incretins are gut peptides that work by augmenting insulin release. So these agents, they mimic the action of natural incretin hormones, effectively stimulating insulin secretion from the pancreas when the blood glucose levels are elevated, and therefore they are considered as incretin mimetics. Examples of GLP-1 analogs include exenatide, given at a dose of 5 microgram subcutaneously in the beginning, twice a day, 15 minutes before meals. It is given 6 hours apart. And it should be avoided if eGFR is less than 30. The dose should be increased 4 weeks after to 10 micrograms twice a day. Next, similar category include DPP-4 inhibitors, which are dipeptidyl peptidase 4 inhibitors. DPP-4 is a glycoprotein that is found on the cell surface of many cells. It is a serine protease that breaks down peptides from amino terminus to small proteins or oligopeptides. These drugs, they are used mainly in type 2 diabetes mellitus again. They raise the levels of GLP-1 and GIP, which is gastric inhibitory peptide, and therefore improves insulinotropic effect of glucose. Examples include sitagliptin and vilagliptin. It is given as an alternative to insulin, especially if eGFR is more than 50. It is preferred in obese patients since they decrease appetite. Last category of hypoglycemic drugs include alpha glucosidase inhibitors, example being acarbose, which is given as an add-on drug. It is comparatively less effective than the other drugs. It decreases the breakdown of starch to sugar. Dose being 50 mg chewed at the start of each meal. Start once daily, maximum up to 200 mg in 8 hours. Side effects of this drug include flatulence, abdominal pain, or diarrhea. Let's see in brief how to use and when to use insulin in case of diabetic patients. First, we start by mentioning finger prick glucose estimation in patients who are on insulin therapy to closely monitor the blood glucose level. The ones done before meals is to monitor long-acting insulin doses, whereas the ones done after meal is to monitor glucose following short-acting insulin doses. If we talk about subcutaneous insulin, we start with ultra-fast acting insulin, which includes Humalog or Novorapid. They are injected at the start of the meal or just after the meal. Example is isophane insulin, which is variable, its peak being around 4 to 12 hours. Then we have pre-mixed insulins along with ultra-fast component. Then we have long-acting recombinant insulin analogs, which include glargine and detamers, mostly given at bedtime. Common insulin regimen. Formulating a proper insulin regimen is of utmost importance for proper diabetic control, which would be systematic and easy for the patient to follow. In order to do that, the regimen should be planned according to the lifestyle of the patient. Introduction of disposable pens, which has a fixed dial dose, should be done where the needle is inserted 90 degrees to the skin. Injection site should be varied each time, either outer thigh or abdomen, and the needle should be changed daily. The regimen could either be BD biphasic regimen, that is twice daily with pre-mixed insulin by pen, or QDS, that is 4 times before meal, ultra-fast acting insulin along with bedtime long-acting insulin. Long-acting insulin analog is useful mainly in type 1 diabetes mellitus for achieving flexible lifestyle. Example for adjusting doses with the size of meals and exercise. It can be given once daily before bed, and also when switching from tablets in case of type 2 diabetes mellitus, long-acting analog could be used. More than 1 unit per 24 hours for every unit of BMI in adults is the calculated dose. It should be considered returning metformin plus minus pioglitazone if needed for a tight control and the patient is unable to use a by BD, that is 2 times daily regimen. Dose adjustment for normal eating, also known as DAFNE. This includes training in flexible intensive insulin dosing for improved glycemic control. Next topic includes subcutaneous insulin dosing during intercurrent illness such as influenza. Here, illness often increases insulin requirement despite decreased food intake. So, it is important to maintain calorie intake, example using milk, etc. The blood glucose should be checked more than 2 times a day and look for ketonuria in these patients. There should be increased insulin doses if glucose increases, that is, if blood glucose increases. 2 hourly ultra fast acting insulin, which is preceded by a finger prick glucose check, should be done. Also, the patient should be admitted if there is excessive vomiting, dehydration, or if the patient is ketotic. If the patient is a child or a pregnant lady, they should be admitted and monitored immediately. That's all for now. See you soon with more detailed videos and interesting topics.